Thank you. Thank you very much. All right. Well, I appreciate so much the opportunity to talk to you all today. I think this will be a bit of a different and maybe a departure from some of the history of this lecture. I think my background lends itself a little different to a different approach, maybe a little different angle than some of the distinguished folks who have come before me. But hopefully you'll find it interesting and educational and maybe a little entertaining along the way. So I'm going to start. Let's see here. The title of building, this was a very fancy title that I started with a long time ago that sounds really kind of cool, but as I started creating the subject matter for this, I realized that it was taking me in a little bit of a different direction. So bear with me. You may at the end of this go, you said this was the title. I'm not exactly sure how we got there, but stick with me. Hopefully we'll get to bring it full circle by the end. So I'm going to tell you a little bit about me, just because I think this introduction to both myself and the subject matter will inform the sort of why about why we're going to talk about what we're talking about today. A little bit about me. Anybody recognize that city? That's Pittsburgh. That's where I was born. I was born there to very young parents, and nobody in my family had been a physician. Nobody actually in my immediate family had gone to college, and so it was a really interesting experience. When one day, when I was 8 years old, I was watching TV. And anybody know this TV show? It's on reruns occasionally, but it was in the 70s. It was a great show. It's called Emergency. And I pointed at the TV show and I said, "Mom, that's what I want to do." And she said, "What, do you want to be a firefighter?" Because, there's like fire trucks and stuff in there. And I said, No, I want to be that. And it was the folks in the white coats who were the ER doctors. And she said, "You want to be a doctor?" I said, "Yeah, I think I do, Mom." And I remember her saying, "Well, son, I don't know how to tell you how to do that, but I know you're going to have to do good in school. So make sure you study," which was not wrong. This was my high school, Herndon, Virginia, Northern Virginia, outside of Washington, D.C. I went to James Madison University for my undergraduate. I played football there. I went to college, medical school at the Lake Erie College of Osteopathic Medicine. I was in the second class ever in Erie, Pennsylvania. That was an adjustment for a kid from, well, then I was living in Virginia, to 140 inches of snow on the lakeshore. But that was a great time to be inside and study, which is what I did most of the time I was there. At the same time, ER was premiering. I was in medical school. So any fans of that old show? I know that's old, right? But ER was a pretty awesome show, right? I saw myself, because I had always wanted to be an emergency doctor, I saw myself in that show, and I saw myself as Dr. John Carter, right? He was the med student, and then he became an intern, and that was almost exactly along my path educationally. So it was pretty cool to have had that. Again, when I started this whole thing, TV show. When I'm going along, sort of TV show, right? I did my residency at St. Luke's Hospital in Bethlehem, Pennsylvania, in emergency medicine. I did most of my clinical career at Carilion Clinic, which is in southwestern Virginia. I've been an emergency physician now for 23 years. I worked at VCOM as an associate dean and senior vice president, which is in Virginia. And then I worked for HCA Healthcare, which is a big hospital corporation. My job there was building residency programs and postgraduate training for physicians. I went back to VCOM for another short stint, and then today. So here we are at the Illinois College of Osteopathic Medicine in Chicago. Very excited. It is correct. Today was our big launch on social media, announcing to the world that we are in fact open for business, taking applications. It's been a 2.5-year journey to get to this point. I tell everyone it's like the preseason in football, right? So I was a football player. You think in a lot of sports analogies. We've just worked all this time to get to play the games. And so now we are eligible, we're on the field, we get to actually do the work that we've been working so hard to get to do. So about Illinois Com, I want to tell you about this too, because this also informs why we're doing Illinois Com. Illinois Com has a mission of training physicians, exceptional physicians, to leverage the interconnection of physical and mental health. Why that? Because our parent organization is called the Chicago School. And the Chicago School is a national university focusing on mental health. They have doctoral, master's, and undergraduate degrees all primarily focused around psychology. And so when they started to formulate this idea of extending their mission into medicine, it was natural to partner with osteopathic medicine because of the synergies in our philosophy. We want to address the issues around equity and access in medicine. We want to train physicians from communities who lack access, of which there are tons, both in the rural parts, around here obviously, in the rural parts of Illinois, but also in the urban parts of the city. There are plenty of places in the city of Chicago that do not have access to primary care doctors. It's alarming. And in some places, it's worse than in some of the rural places that I've worked trying to get physicians into. So that was a very big eye-opener for me. And we want to focus our research on that intersectionality of mental and physical health. We have created what's called a Mind in Medicine course, which is going to explore a lot of that intersectionality, behavioral influences, being able to do mental health screenings in primary care settings, managing complex cases, taking into account the psychosocial factors that contribute to wellness. And really, we want to prioritize student well-being, which is a huge piece of this. It is more challenging to be a medical student than it ever has been, and the prevalence within the medical student population of things like anxiety and depression and ADHD are higher than they've ever been. And being able to help teach the students, while we instruct them how to take care of patients effectively, also how to take care of themselves effectively, is one of the challenges we intend to take on full force. So curiously, I always start this, when I start talking about osteopathic medicine, just a quick nod or show of hands, how many people understand what osteopathic medicine is distinct from MDs? A couple. Good, okay, that actually makes me feel better, because I generally like to start with saying, okay, hey, let me tell you a little bit about why we did an osteopathic school and what DOs are. I'm actually a DO as well, of course. So there are 4 tenets of osteopathic medicine. This is just a quick primer. The body is a unit. The person is a unit of body, mind, and spirit, meaning we have all of these things that contribute to ourselves. That the body itself is capable of self-regulation, self-healing, and health maintenance. That structure and function are reciprocally interrelated, and that rational treatment is based on understanding all of those things. So this was kind of radical when it came out about 150 years ago. Not so radical anymore. I think this is what people expect. This is what people understand, that there are more things to our health and our wellness than just our physical bodies. That if in fact we don't address all of the parts of a person that make them a person, and we include those approaches in our approach to wellness and how to be a physician that actually guides them to wellness, that we're neglecting something. So osteopathic medicine in the US was founded in Kirksville, Missouri. There are 42 accredited comms at 67 locations, 38,000 osteopathic students in the United States right now. That's 1/4 of all the medical students in the country. There is a single residency training system now, meaning that all the MD and DO schools all coalesce into their graduates going into residency training in one system. And then we practice in all the states and all the specialties. So a few of the DOs that are out there, all 3 of the last presidents had DO physicians. J.D. Polk is the chief medical officer at NASA, the president of Federation of State Medical Boards, Omar Latif, president CEO of Rush. He's been a supporter in kind to us in our development. Dr. Budev at the Cleveland Clinic. There are a lot of prominent DOs, and I think that's a thing that people are starting to understand, that we add a dimension to patient care and to the house of medicine that is valuable. And so we're looking forward to sort of building this new osteopathic school. Okay, so into the meat of our talk. Why I've chosen to talk about these things and specifically address mental health issues is because there is an enormous need in the country for our patients, in the house of medicine for our medical students to be healthy and to actually have better mental health. I'm going to show you a brief vignette. There's going to be a few clinical vignettes along the way, and they're intended to illustrate a couple of things. These are real patients that were my patients over my emergency medicine career. So I was working one Christmas Eve. It was a bummer to work on Christmas Eve. It's never fun. But I had a 32-year-old woman who came in who was actually quite cheerful, but had become forgetful and maybe a little fumbly and stumbly with her walking, and she just wanted to kind of come get checked out because she was pregnant with her first child. She had graduated from law school, recently was joining a law practice, and was sort of on the cusp of her young life. And she said, I think it's just me being pregnant. It just changes the way you think, and I've heard all these things about pregnancy brain. And so I did an examination with her, and I felt like there were some things that warranted a CAT scan of her head, and this is what it showed. So this was my patient on Christmas Eve. Okay, this is a glioblastoma, which is a terrible, aggressive brain tumor, and this really happened. The radiologist called me before I even saw this, and said, "My heart weeps for this woman," and that's never a good thing to hear from your radiologist, especially to have to go and tell her, right, on Christmas Eve, that this is what's happening. So, why do physicians need resilience? Burnout is historically high. 40 to 50% of our doctors report being burned out. That's a lot. The components of this: exhaustion, depersonalization, feeling a reduced personal accomplishment because of any number of factors in their lives, the corporatization of medicine among them, the loss of agency is another. The stress of sort of the professional practice and making it work. I illustrated that case because that was sort of a regular day. That's the kind of stuff that goes into that personal stress. Suicide is a real problem in the physician population. We lose about one physician a day dies by suicide in the United States. Those numbers are very high compared to the general population. Female physicians are actually at 130% higher risk than their matched female population. And the risk factors are a lot of what you might expect. There's depression and exhaustion. We're taught at some point, either implicitly or explicitly, that we somehow can't get sick, that we're not allowed to be sick, that we don't suffer, that somehow we're made of different stuff than the rest of our humans. And so we also have a tendency towards perfectionism, if you might imagine that could be, right? We hold ourselves to a very high standard, and we're taught this sort of perfectionistic streak. There is an element of substance abuse and depression. I've seen it in my colleagues in the emergency department from time to time. And of course, malpractice is an ever-looming thing. It's very hard as a physician. I actually never was sued in 17 years in the emergency department. That I consider to be very fortunate. But I had a lot of friends that did go through that. And it really affects them in a way that is very deep, because we're very invested in our work and we really take it personally of what we do. And we do the things we do out of very personal reasons. And so when that happens, it can really have a profound effect on people. I wanted to show this video. We're gonna try it anyway.
33-year-old female presents with multiple self-inflicted stab wounds, blood pressure 60, heart rate 140, Glasgow Coma Scale 13. Large bore IVs have been established in the field. She's obtunded. The plan is to get her to the operating room as soon as possible. I came around the corner, and this is Trauma Bay 2, and this is the bed. And there I saw one of my colleagues, somebody that I work with, somebody that I know very well professionally and personally as well, on this stretcher after she had injured herself, self-inflicted stab wounds. She was getting prepared to go to the OR with an excellent trauma surgeon, and I was very confident. I talked to her. I was very confident she was going to do okay. I got a call back from the trauma surgeon and said she didn't make it. I was devastated. How could somebody, some young, incredibly bright person who seems to have all of it together, do this to themselves? What could possibly drive somebody to do that? I've asked myself the question of what would I have done differently? I knew she was sad. I knew she was struggling a bit. I never really realized how sad she was, After the fact, I talked to one of her friends. The one thing that she said to me that kind of just rings in my head to this day is, she said she was hopeless. She felt hopeless at one point. I'm not sure there's much I could have done, except, the hope is maybe by getting the message out to others that, you know what, it's okay to raise your hand and say, hey, I'm struggling. I'm feeling a little hopeless. It's okay, and we have something to help you. As a medical director, and I would argue as a good medical director, you're trying to keep your group together. You're sensitive to the fact that there are signs. We're not trying to make you a psychiatrist, but if you have a provider that's never been late, who starts showing up late, or is struggling, or has some substance abuse issue, some other issue, then those are obviously warning signs that there's something going on in their life. This is a big deal.
A very profound illustration of what I was saying, but understanding that these are real concerns, that this really does happen. It's not that unusual. It's not an anomalous thing, that we really need to care for this group of people is one of the driving factors for why we're doing what we're doing at our medical school. So here's another vignette. This is a little different perspective. So a 54-year-old male patient, well known to the emergency department staff, presents with a chief complaint of chest pain. This is his third visit this week, and it's his 22nd visit this year, but it's only September. And it's always for chest pain. And this fella has had an extensive workup. And when I say extensive workup, I mean he has seen the cardiologist many times. He's actually had a catheterization. He's had stress tests. He has been worked up as far as we know how to work up people for chest pain. He has underlying bipolar, anxiety, and OCD. He's on his medication. This was his EKG that day. Now, the doctors in the audience will recognize this immediately. Anybody who knows what an EKG looks like when it's not a great one, that's not a great one. Those are ST segment elevations in 2-3 and AVF, which corresponds to an inferior wall myocardial infarction, which is a heart attack. He was taken to the cath lab and had a stent placed. So this is the more scientifically related part of this talk. And so mental health is not just to make people feel good emotionally. Mental health has real and profound effects on the physiologic responses of your body. And there is a bunch of research along these lines, right? So I've tried to document these if you're going to get the slides afterward and you want to read some more about it. But coronary disease has a worse progression for those people with moderate and severe depression after controlling for all the other variables in their life. They actually die more frequently from cancer when they have depression. Inflammation impacts several neurotransmitter systems in the brain, including serotonin, dopamine, glutamate. And so this has a direct impact on so many other systems. So depression impacts inflammation. It impacts immunologic response. The glucocorticoid response is related directly to chronic stress. So we have found that response in patients of children with cancer, spouses of brain cancer patients, and in persons reporting high levels of loneliness. And if you can't regulate that system very well, it has impacts on all sorts of inflammatory problems, respiratory issues, coronary disease, diabetes. So the idea that we can just take care of the physical part of a person and leave that mental health part to somebody else, to some other system, and really feel like we're doing good things for our patients, I think that is slowly fading away, to be replaced by a concept that really mandates that we examine these things. And so that's what we intend to do in our school. We intend to incorporate that concept of including the mental health care in the care of their physical bodies. And that could hardly be more osteopathic in its in its outlook. Okay, this one's kind of a hard one. So I was called, this is me working in the emergency department, I was called to the bedside by my colleague who had not been in practice that long, had been on a residency just a year or two by that point, and he was taking care of a 9-year-old girl who had come in cardiac arrest after a car accident. The strange thing was there were no signs outwardly that she was injured. There was no bruising, there was no bleeding, there was nothing that you would look at this little girl and think this was wrong. She was in the third row seat of an SUV that was hit from behind. And so I talked to him and I said, well, you know, the only thing this can be is something in the neck. We haven't seen the x-rays, let's get the x-rays. And this wasn't her x-ray, but this is an x-ray of the condition that she had. And I don't know if you can tell that space right there is a lot bigger than it ought to be. Right? So this is called OA dissociation, sometimes called an internal decapitation. So that's profound and irreversible spinal cord damage, and it led directly to this poor little girl's death. So that happens. And anytime that happens in a hospital setting, in an emergency department setting, it's incredibly difficult because we're all humans. Our teammates have kids, they have families. But that's not the only part of this that's hard. It's what happens next. So you leave that room, and this happened, this is exactly what happened. You walk out of that room and you go to the next door, and the person in the next room is having a heart attack, and they don't know what you just dealt with, and they need you to deal with that. And they don't really care about what just happened because they don't know about it, and they want you to try and help them stay alive. And then you leave that one and you go to the next room and there's some person complaining about something that seems somewhat insignificant. They're complaining about abdominal pain, they've been waiting too long, and they're sitting there eating a bag of Cheetos, not particularly sick looking. But again, you leave that room and then you go and take care of another person with a cardiac disease problem. And then you leave that room and you realize that that little girl's parents are also patients. And you have to care for them, and you have to tell them what happened. And the take-home message is that our brains are not, as humans, are not really wired for that level of stress and trauma every day. And I don't care if you train for it like I did for 4 years before I ever got to see a patient on my own, or if you're in a different specialty. We're all made of the same stuff up here. And it's important for us to help our colleagues, to help our future colleagues, our students, understand that that isn't a weakness. That's just a condition of the job we've chosen. And in order to take great care of ourselves and to be able to take great care of our patients, we have to look at this. We have to look at that and understand that it's critically important that we leave space for us to help make it past this kind of stuff. I have seen any number of terribly tragic things and had that kind of, it would have been a natural reaction, but I just left it. And now that I'm not in practice at this point, they come back to me. They come back to me. And I think that's important to deal with, and it would have been better for me to deal with it contemporaneously. But, okay, so let's talk about med student burnout. This is a thing. Med students, depending on who you read, somewhere around 35-40% of med students report being burned out. Med students, they haven't gotten into the clinical universe yet, but they're burned out. Why? They're exhausted. This is a hard course of study. This is hard work. It's competitive work. They are perfectionistic, just like they are when they become physicians. They didn't learn that in med school. They got there that way. They actually develop cynicism by the time they finish med school, which is a crazy thing to think about because they, again, haven't even really been out there doing this work yet. But it gets into the culture somehow. And so what contributes to this? They're in a situation that typically has lower support systems, higher stress levels, lack of control over their lives. They're told when to go and where to go and what tests to take. There's no agency there. A lot of them have had thoughts in that dark time of quitting. Me too. There's always that dark night of the soul where you're like, I'm only a year and a half into this process and I've got another 7 years to go and I'm not sure I can do it. Sometimes they have negative life events. They might, and that can range from failing a test. These students a lot of times have never failed anything. And that's tough. Sometimes they can feel dissatisfaction because it's not exactly how they pictured it was going to be. Sometimes they question their motivation. Why am I doing this to myself? And general distress. And a lot of them don't have the coping strategies that they need to deal with some of these things. And that thread goes all the way through undergraduate education, undergraduate medical education, graduate medical education, and practice. We don't equip our physicians and future physicians to deal with this because we allow that perpetual idea of we're made of something different and we don't get affected that way. So what we seek to do at the school, among a lot of other things, is this idea of development and fostering and bringing in resilience and grit, right? So resilience is the ability to adapt from an adverse event. This is going to happen. Right? This is constantly in medical school. This is facing intensive coursework, evaluations, competitive environments, emotional challenges, like I've mentioned before, the confrontation of human suffering, the physical demands of medical training. It's not a walk in the park. It's actually it's more controlled than it ever has been before in terms of hours, but all that really means is that when you're a resident, they limited your weekly hours to 80 a week. So you can't work more than 80 hours a week as a resident, and that's better than it used to be. And grit. So where resilience is more rearward facing, recovering from adverse events, grit is more frontward or proactive. It's the idea that you have to persevere and have a passion for your long-term goals. Medical education is a minimum of 7 years after graduate, minimum. Some fields requiring 11 or more. I've known several who have continued their training. One of our faculty members did a 5-year surgery residency and a 2-year trauma fellowship and a 2-year transplantation fellowship. And it's like, wow, like, you got to get out and get a job, right? Like at some point I actually have to be gainfully employed. But the idea of medicine as a calling is actually something that I've found to be very sustaining. That it's not just a choice that is intellectual, but you feel called to it. You feel like it's your vocation that you want to pursue, that it lends itself to your particular makeup. So resilience is actually also emotionally regulatory. So you have to be able to kind of regulate that reactivity and emotionality that comes with adverse events. And we have to kind of have a process-oriented and broadly applicable development process. Grit is almost, in some cases, harder to develop. It's able to be developed, but some people feel like grit, more so than resilience, is a trait that some bring to the party. And so part of what we'll do in our new class is to try and identify students that have some of these pre-existing conditions and situations like grit and the ability for resilience, but we also hope to develop those. Grit is very consistency focused, and I tell the medical students this all the time, and prospective students. Medical school isn't necessarily so cognitively complex in its difficulty. It's not, certainly the things that the S&T community deals with are way more cognitively complex than anatomy, right? Anatomy is anatomy, and it's not difficult to understand the anatomic structures, but it's difficult to remember them because there's thousands of them. And so medical school is not challenging necessarily because of the complexity of the material. It's challenging because of the volume of the material and the need for consistency, the need for grit, and the need for dedication to stay on task. That's what makes it really hard. So both of these things are critical. We hope to develop those so that if you can see the thread that I've been weaving here, the med students need this, practicing physicians need it, and mental health plays such an important role in the day-to-day work of the patients that we see. So you see patients every day. I have a couple of friends who are looking at our school as a career, and he's a family doctor, and we talked recently about what his experience day to day was like. And he said, I spent most of my morning filling out mental health care paperwork. He said, it's a huge part of what I do. And I don't think that's unusual. I actually don't think that's unusual in family medicine. We know that more than 50% of people who seek care for mental health for the first time do so with their family doctors. They seek it from their doctors first, mostly because they don't know how to access it anywhere else or where to start. But I think it's important for us to create a culture at the med school level that helps these students understand how to interface with that process, right? I'm not seeking to create all psychiatrists. People say, oh, you're going to make a bunch of psychiatrists. No. But if you're an orthopedic surgeon and you're going to do a hip replacement in somebody with depression or anxiety or any number of other concomitant behavioral health care problems, and you don't think that that's going to impact the way that they recover, I think you're mistaken. So I think being aware of it, no matter what they do, is sort of a really strong imperative for why we're doing what we're doing. So how do we build this? How are we going to do this at our school? There's a lot of things that we're going to incorporate. So modifying our curriculum to include things that are healthier. So incremental challenges, not blasting them out of the gate, right? Not giving them both barrels, if you will, of testing as soon as they get there. Setting them up for success. Being able to have things like a pass-fail system, which we do, has been definitely associated with higher levels of satisfaction and less levels of stress. Developing in our educators a competence around growth-oriented feedback and modeling, helping our faculty show what it's like to actually have healthy habits. Also a challenge, right? Because sometimes they come from a different generation, which came up with different strategies and teachings. And so having to incorporate some of this into our faculty is also a goal of ours. Recognizing and rewarding those behaviors. Structural support services. Student support services are critical. Having them integrated into routine educational activities. Learning communities is another big area that we do so that there is support from their peers and from faculty mentors. Reducing stigma around seeking help, another big deal, big deal. Students don't feel like they can sort of be public with any of those struggles, not really public, but open about the struggles, and we have to normalize a lot of that. And scheduling that respects physiology, right? Not over-testing. We're not going to kill them by testing. We're going to respect the fact that they have physiologic needs too. They have to sleep, they have to eat, they have to have breaks. Being able to work with that system structurally that gives them the best chance at developing resilience and grit. And then seeking help as a strength. This is one of those big professional development things that happens in medical school. To get to med school, we make people feel like it's such a competition. It's such a competitive environment to get into school. And then as soon as we get there, we tell them that medicine is actually a team sport, which it is. None of us practice completely by ourselves, unless you live on an island someplace, but we have specialists that help us in every different facet of our practice. And so understanding that we have an integrated practice model and that the sooner they develop that mentality around approaching their peers, the better they're going to be. And so developing collaborative models early, even in med school, will actually help them. Because all those students are going to be their colleagues. They're not competitors. And emphasizing different types of feedback and being able to incorporate competency-based evaluations are critical as well. Opportunities to learn from mistakes and to remediate without the sword of Damocles over them waiting to drop and sever all of their hopes and dreams, right? We also have to understand that that's how the real world should work. That when things happen and don't have great outcomes, that we don't punitively affect ourselves, but we actually seek to learn from them. And that's what we want to incorporate. Okay, so that was predominantly what I came up with. I thought it would be a little different, but the idea that we have to address this from the very root causes of mental health and wellness for both our future patients and our future doctors was sort of the thing that I wanted to give to you to take away from this. So I don't know if we're baked in to have any time to have any questions. If you have any,
We are.
I'll answer them best I can. I'm sure Dr. Kendi would help me if I can't answer them as well.
Yeah, thank you for a wonderful talk, and I want to open the floor up to questions. In the meantime, while you think of your questions, I have one for you. I come from a trauma background, have a family that's military. What correlations do you see between our veterans and our emergency staff?
So you mean like when I was working in the emergency department itself?
Just in general and what
yeah.
we're exposed to, both them on the
I think
veteran
there's
side
actually a
versus
lot
us.
of a lot of correlation between the environment. And so we had, actually in every emergency department I've worked in, we've had a lot of veterans that have trained as medical professionals and worked in our armed services who then come and work in the ER. And frankly, they're exceptionally good at that environment, right? They know how to sort of work under fire. It's obviously not the same in the civilian world, but we frequently talk about this idea of sort of going to war at the beginning of the day when you come in and there's a waiting room full of people and everything's chaos, and you look around and you know that there are certain people that you can rely on, and we're going to go for it and we're going to get through this day. People that a lot of times that were veterans, come from that background, they're the ones that plow right into it and go, okay, we're gonna do this or we're gonna get through it. So always been valuable to me. I hope that we have a good cohort of armed services focused students. Our military needs great doctors. I have a number of friends who have practiced, and actually one fella on our board of directors is a retired 2-star general, and I think that will help inform our approach to getting good students, good engaged students that have to have careers in military medicine.
Hi, I'm Casey Canfield. I'm an associate professor in engineering management and systems engineering here at S&T. And so I'm kind of curious about how you're thinking about like new artificial intelligence technologies and like how you see that kind of changing med school, changing like medical practice, but also how you think that connects to this burnout piece. Because I could sort of see it go both ways of like there could be ways it helps with reduce burnout, but there also might be ways it like makes it worse. And so I'm kind of curious how you're thinking about AI technologies.
Great question. I get it all the time, right? So I tell my team that if we had been building this school 5 years ago, or if we had been building this school 5 years in the future, a lot of those questions around AI would be irrelevant because they would either not have come up yet or would have already been solved. So the problem is I know how I would incorporate AI and some of the educational technologies around AI specifically right now if we were to open today. But the problem is I open in 1.5 years. And so in 2 weeks, what's available is going to be markedly different than what's on the market right now. I can tell you that med students are incorporating these technologies every day. Residents are incorporating these technologies every day. And in most cases, they really do contribute to good outcomes. I like to use the illustration that, I put up an EKG earlier. I've probably looked at 2,000 or 3,000 EKGs, maybe 5,000, I don't know, a lot, in my career. But when you put it into a a computing system that has a background of millions of EKGs that far exceeds any of my own capacities. And those things are tuned correctly to diagnose abnormalities. They're better than me. And when you get to that point, it's doing patients a disservice to not use it, to not recognize your own limitation and say, no, this system knows better than I do because it has more information than my brain can hold. So I think that's one of the things that's going to continue to develop. There will be an increased level of areas of expertise where the technology will make us better doctors. And I fully embrace that. Another thing that's happening with AI right now is, every hospital uses what's called an electronic medical record. So a lot of hospitals use something called Epic. I don't know if you guys have ever heard of Epic. We actually have a partnership with Epic. And so they have a product for medical schools called Lyceum, and we're one of the first medical schools in the country to utilize this. The idea is that our students will learn how to document in a real Epic system so that when they go out into the hospitals, they'll be proficient in how to create a real medical record. But very recently, Epic incorporated AI technology into their documentation, and what I've heard is that the clinicians are overjoyed to have that technology because what it does is it reduces what they call their pajama time, which is the time they sit at home trying to document all the things they did that day before they go to bed while they're sitting there in their pajamas. So a lot of doctors are saying, this is great. I get to go home now and my charts are done because the AI technology helps me fill in where I need to fill in and gets my documentation done much quicker and much more accurately. So I think there's a diagnostic interface that's happening. There's definitely educational technologies that are going to evolve. So being able to incorporate virtual patients, we can do this right now. So we can put patient demographics and medical conditions into a system like Claude and tell them to act like this patient and conduct full interviews. And it will actually give you educational experiences along the way. You can ask it questions outside of that encounter, stop, take a pause, ask it to help develop a differential diagnosis. So I'm actually quite optimistic about it. Where people get nervous, I think, is because you're afraid that somehow it's going to replace doctors. I don't think that's going to happen, at least no time soon, because I think there is still value in that patient interaction where you're sitting in front of somebody. And in fact, the AI freeing you up, because for the last decade or so, you go into your doctor's office and he or she is sitting at a computer typing, looking at you, right? So tell me about this. Did you have this? Okay, and they're doing this. And that's a very dissatisfying way to see the doctor. If you have a system that actually takes that out of it and you can sit in front of somebody and look them in the eye, hold a hand, put a hand on a shoulder, empathize, I think that is the things that humans do really well right now that I don't see being made obsolete in the very near future by the AI technologies. And so what I think it'll do is allow us to be better doctors, to have a broader diagnosis and knowledge base, and allow us to focus on the humanistic parts of medicine that really is what patients want, right? I never, in all the years of my emergency medicine practice, did I have a patient ask me what my board scores were or ask me what my GPA was in med school. Never, because they don't care. They see me in this coat, right, with a stethoscope around my neck. They figure he knows enough to be a doctor, right? He's on staff here, he's credentialed, you have enough knowledge. What they care about is how you treat them and how you translate that knowledge into the interaction and how you validate their concerns and how you actually act to them. And that's what patients value. And I think we can focus on that. I think if we utilize the technology to help us free up some of those other parts, we can really focus on the patient care parts that patients find valuable. And so I'm encouraged, I'm excited. Most of my teammates are excited. We have some that are like super excited. But I would love to tell you what it's going to look like when we open the doors. I don't know exactly, but I think it's going to be cool no matter what it is.
I have a question from our virtual attendees. As a patient, how can we be helpful or encouraging to our providers?
How can you be encouraging, what was it, to
Our providers.
To our providers? Mm-hmm. Wow. That's a great question. I think most doctors, In fact, I'm going to go out on a limb here and say I've done a lot of interviews. I've been on admissions committees. Dr. Kendi has been on admissions committees and headed admissions committees for medical schools. Almost every person that I've ever interviewed said some version of the same thing, which is, why do you want to be a doctor? I want to help people. I want to help people. That's a very normal, common, some variation of that. What I think in my career was some of the most rewarding parts of that journey was when a patient would just genuinely thank me for doing my best to help them. Whether it was a good outcome or not a good outcome, but just the thanks of it, and that may seem like a very basic thing, but it doesn't happen as often as you'd think. Most time patients are feeling really rotten when that's why they come to the doctor's office, or in my case, the emergency department. They're having a terrible day. And they don't think like, hey, the doctor's probably running around like a crazy person trying to see all the patients that they can and trying to balance their lives, and they sacrificed a decade in their 20s to get to be able to do this work. I think just an expression of gratitude is the simplest and most universal way that you can help your docs feel better. Again, I don't mean to make it sound like nobody ever says thank you. They do, but I think consistently, that gets you through the day. If you know that each person is just, hey, thank you for taking the time to talk to me today, I'll do it all day long.
So I really enjoyed your talk.
Yeah.
I just have a question on what are your thoughts on how we as pre-medical educators can incorporate resiliency training into the curriculum so that these students are better prepared when they ultimately go to medical school?
Great question. To some degree, I feel like going to medical school is one of those things that's really hard to be ready for, no matter how much you think you're ready for it. I had a mentor when I was a young man about to go to medical school, and I asked this physician who was letting me follow him. I was about to get married, actually, and I asked him how to sort of be ready for all the things, and he said, listen, I think there are 3 things in life that you're not ready for, no matter how much you think you're ready for, and one of them is getting married, the next one is having children, and the third one is dying. And he said, so I don't care how well you think you're prepared for any of those three things, you're not. So medical school's kind of in that category, but I think that the incorporation of the realization of what the real demands are, I didn't know when I went, no chance. But the ability for students to have a self-evaluation of where the pinch points are going to be in their lives, and it's going to be different for every student. That's part of it. It's somebody who's an exceptionally good student in one area, but struggles with loneliness or interpersonal relationships. That's going to be the struggle point for them because it's going to be lonely. I mean, you're going to be stuck in a room studying a lot, and you're not going to have a lot of those relationship opportunities that you do. But that's not the same for everybody. So students who are really brilliant students, but maybe lack disciplined study skills, that's going to be the touch point for them. And so getting students prepared as they can be to understand themselves, and not in a way that they're going to put out there for an interview, but understanding where their own personal weaknesses are and where their challenges are, will pay enormous dividends, because then it won't be a surprise. Some students come to med school and they've never had to work hard in their life, like literally. They're just that smart. I'm not one of them, but the students that I've known and some of my classmates, they're brilliant, and they never had to work hard because they're just that smart. Med school has a way of sort of confronting that. And so if you think that you're a great student and you really haven't developed that skill, I think that's probably the best thing you can do for them, is really help them with their own self-awareness and their own evaluative skills of themselves, so that it's not a shocker when they come, so they know what's coming. It's hard to know exactly until you do it, but I think that'd probably be the best thing.
Thank you so much, Dr. John Lucas. And so we truly enjoyed this 1 hour, and great talk, and also excellent questions. So let's thank our speaker one more time. As a token appreciation, on behalf of NextGen, I'm going to present you a the plaque, and hope you like it, and then put on your table.
Very nice.
Yep.
That's gorgeous. Thank you.
Okay.
Beautiful.
Yep.
Should I? Oh, you
Oh, I'll put it back. Yeah. Thank you. Yeah, for the audience, if you have questions, Dr. Lucas will stay here, and so you feel free and to ask questions. Thank you very much. Thank you, everyone.